Thanks for coming. Just before we get started, a quick announcement. I want to make sure that everybody's aware that we're having a global health celebration, which the lovely Kim is now displaying, on October 28th at Dejo, over along the lakefront. It's a evening celebration with a lot of our graduates from the global health programs, along with some shenanigans and tomfoolery that will subsequently ensue, just to basically kind of bring back together for homecoming weekend global health graduates and people that have worked with our program.
And also the great global health faculty and staff, good food, drinks, and conversation.
Excellent. See Kim for further details. Or take a look at our website, ghi.wisc.edu. We're so cool we don't even need a www. All right, so I've got the pleasure of introducing Steve Warrick, who is here as part of our Midwest Global Health Consortium of pediatric educators, and is going to talk about his resident experience programs on the Navajo Reservation. He did undergrad at the University of Kentucky and med school at Louisville, and then residency at Cincinnati, where he was also chief resident, and he's now currently an assistant professor of clinical peds in the Division of General and Community Pediatrics, and assistant director of the Global Health Pathway Steering Committee, and faculty advisor for the Global Health Interest Group. And he is originally from Kentucky, resides in Cincinnati, and has a wife and a daughter. So welcome, Steve, and we're looking forward to hearing about your experiences. Thanks.
And I apologize for the scratchy voice. This is courtesy of a 16-month-old daughter and some viral process she's brought into our house that now everybody is having, including our grandparents. So I appreciate you guys inviting me to do this, and I'm sorry for the last-minute confirmation with some schedule stuff. It was kind of back and forth, and I apologize. So I know it made work for some people quite difficult to get the ads out and in time and all that stuff. So my apologies. But I want to tell you guys a little bit about a program we've built within our institution and in a partnership with the Indian Medical Center in Gallup, New Mexico, and the resident opportunities we've built over a now 6 going on 7-year continuum with this relationship. And we really are looking in the future to see some of our partner institutions, particularly through the consortium for which we're here for the meeting this week, to hopefully be able to get on board and have those opportunities available to some of their residents as well, which would clearly be some of you guys. I was asked to give the same talk to some medical students recently, and I told them this is very focused on what we have established right now, which is our resident program, but I think there could always be some opportunity for medical student engagement. We just have to work on that and figure out what could happen on the other end from their standpoint without overwhelming their system. So first off, I have nothing to disclose. Objectives, I want to talk a little bit about the history of the rotation, talk about what we have going on currently, and then share some of our future plans and sort of what we're working on in the process currently. So a little bit about the program. So this first off is a map of the Navajo Reservation. It lies in the Four Corners region, which on here is very small, but down here you can see the red dot is sort of within the Four Corners where the Navajo Reservation is. We spend most of our time in Gallup, New Mexico, which is about 2 hours west of Albuquerque. So we usually start off by landing in Albuquerque and making the trek along the very dry and arid I-40 en route. And then just as a little bit of other sort of thoughts, we have some of our former graduates now who are in Chinle and Tuba City practicing. And I'll talk a little bit about them a bit later. But our residents actually get the opportunity to see almost all of the reservation, even within a 2-week period of being there, even though Gallup is sort of our stepping stone. So this all started back in the spring of 2009 when Children's accepted their first group of Global Health Track residents at the end of the intern year, which happened to be my intern year. We now call it the pathway based on the way everything changes from every 6 years or 5. We have to have a new name for things. But one part of this track or pathway was that you had to have a scholarly project to be able to get your certificate at the end of above and beyond your general residency graduation certificate, a global health certificate. So Stephanie Clark, who is now a nephrologist at CHOP, and I were both interns there, and we sort of sat down one day and said, well, the scholarly project, like, what do you want to do with it? What are you thinking? What the heck am I going to do? We're the first people to ever do this. Nobody's ever done it before. We don't have an example. Let's figure this out. So Stephanie had come from a med school where one of their big keys was that pre-trip prep is really a very important component of a good global health experience. And she added the word, it should be exceptional. Meanwhile, I was one who, where I had come from, one of the big values I had learned was the importance of having faculty on site with you in order to have that positive experience and the good supervision and teaching that you need that you may not always get if somebody doesn't know what your background is. And then we both sat there and talked about how global health is not international. It's right out the window of this room we're sitting in. You can see global health. And so where can we do these things? So we began to collaborate together and said, let's work together and see how we can bring our two ideas together and not work in silos. So we met with Dr. Chuck Schubert and Brian Volk. Brian Volk had worked on the Indian Reservation earlier in his career for about 5 or 6 years in Tuba City. His wife had also worked there at the same time as an obstetrician. And so we started talking and thought, wow, this Indian Health Service has a lot of opportunities and we have good connections. Let's explore this a little further. And the great things about it, it could be a lot cheaper than traveling to Africa. We have an existing partnership. We know the people who are the chief of pediatrics at the Gallup Center. And it could serve both as a global health rotation, and it could be a great preparation site within the U.S. for someone before they experience somewhere else, and the cultural opportunities there are found. So in 2010, in July, Chuck, Stephanie, Brian, and myself traveled to Gallup just to meet with the people and sort of explore this possibility. Is it even real? Are you really interested? Where are we going with this? And then, so we were able to come up with some ideas, and then in September, Stephanie and I traveled back actually for a month, and we did a month-long rotation, which was part clinic and exploring the clinical opportunities, but probably equal or more actually getting out into the community, meeting the organizations, finding out what's going on there, who would be interested in having a resident, what could we contribute, and where could we learn? And where could we learn about something other than just hearts and lungs and the body itself? And this picture here is Chaco Canyon, which is a beautiful canyon about 2 hours of dirt roads away from Gallup, where Brian and Stephanie, who are very fit people, left Chuck and I laying in a shade with heat exhaustion with lack of water. So we had a great time. So I sort of shortened this just for the sake of being able to leave room for questions at the end. But so in 2011 through 2016, what's happened? So 2 of us went in 2010. We started setting this up. So starting in 2011, we have a group of interns now as part of their global health rotation. It becomes more formalized as a month-long rotation. Have a 2-week experience during Gallup, or in the Gallup location. It was 5 in that first year, and has subsequently been 4 residents a year just because of space needs there at their institution. During this time, faculty from Children's go with them on this rotation. So myself or Dr. Volk or Dr. Schubert or a couple of the other former chief residents who've been very global health focused have been on site during the rotation. We've had some residents who decided to do a month-long rotation, some of those who were in the track and decided to go back, some who heard about it from the people in the track and then chose to go try it out. In fact, one of our residents who went back in the spring is actually traveling there later this week to do a month-long rotation again as a follow-up for a rotation just a few months ago. Others have chosen to go to other places because of connections or stories or something they've heard. So, for example, the resident who's in Tuba City, or the former resident who's faculty in Tuba City now, actually chose to go to Tuba City because she knew they had openings and she wanted to go find out what it was like. It was almost like a test drive of what her future career might be. And then we have 4 MedPeds graduates who've taken positions with the IHS and the Navajo Reservation, which we're proud of. Interestingly, none of them were on our track, but they heard about it from everyone in the track. So even though they, at this point, it was categoricals only when they were going through the residency program, but now it's open to all programs combined and categorical. So we've expanded after them. Jessica and John, the 2 on the right, have a new baby. They work in Chinle, Arizona as MedPeds docs. Dave, the gentleman with glasses, actually worked in Pinon, which is a very small rural community clinic in the Chinle service area, and this is his wife and son with him. He actually is now back in D.C. working for the NIH in a different venue, but certainly it was a great stepping stone for him. And then Liz is not in this picture, but she's our resident who's now in Tuba City working. So a little bit about the Navajo, just to kind of, what is the patient population like, which is, I think, really key and very interesting. So first off, it's the 2nd largest tribe of the Cherokee within the U.S. The 2000 census is, these numbers are a little hard to follow, but I'll try to explain them out so they make sense. So over 332,000 U.S. residents claim Navajo ancestry. So they have some lineage there, but maybe they're not full or half or however you want to do it to meet all those criteria we hear about. About 286 say they're Navajo only. So mom and dad are both Navajo, as are both of their extended families. And about 173,000 of them say that they actually live on the reservation, so about half of them. So, you know, some may live in Gallup, New Mexico, which actually isn't on the res, it's a border town, but you cross over I-40 and you're technically still in Gallup, but you're on the res. So it's really kind of sketchy how the Census Bureau drew this out, but this is kind of how it fell. But what I think is really interesting, if you look at the distribution of this population, you can see that it is a very young population with a young median age. So I think you can look at this two ways. Either they reproduce a lot, or they die very early, which is what we're going to get at. So it's more of an earlier death than most Americans. So then there was a really interesting newspaper article in 2015 that came out, and I went looking for this information based on what they tell us when our residents get their orientation at Gallup from the pediatricians there as to what they're going to experience. So I'm going to tell you what the paper article says, and then I'm going to add a little bit to that. So 32% of the Navajo on the reservation, about 15,000 homes, are without electricity. 31% are without plumbing. 38% have no running water. 86% no natural gas. 60% no phone line. And I would tell you that a lot of us would say, well, who really uses a phone line today anyway, right? Well, out there, cell service is pretty limited too, because there's a lot of other infrastructure that's not present that would make that possible. The utilities companies are reporting about 700 new hookups per year with electricity. You have 15,000 without it, 700 a year getting it. It's going to be a long time before those numbers ever shake out, probably many generations beyond me. The average per capita income, $7,300 versus the remainder of the U.S. is $43,000. Now, the $43,000 we know is inflated by people who were debating last night on TV, as well as many others who may or may not benefit from some of their various plans on either side of the aisle. But regardless, this is a very poor community without a lot of resources coming in from the outside as well. And I would tell you, in the Gallup service unit where our residents work, these numbers, the 32%, the 31%, the 38%, go up from into the 50 to 60% range for the patients coming into that pediatric clinic. So they tell stories of how the kid with bronchiolitis who's admitted in the winter is ready to go home on Monday, but they can't discharge them until Friday because the roads aren't frozen, and if they go tonight, they're going to go and possibly get stuck in the mud. They have no phone service to call for help, and when they get home, they have no electricity. Or they talk about the patient with some chronic syndrome who literally the family runs the ventilator off of car batteries that they charge from time to time. And it's their way of life, and they think of nothing different. So it's a very different population and very eye-opening. So the Navajo, I think you probably can figure out with some of these numbers, have some of the worst outcomes in the U.S. They have the lowest life expectancy of any ethnic group within the U.S. This includes African Americans, Latinos, of about 72.5 versus the average 76.5 years across the rest of the population. The government spends half of what they do on the rest of the U.S. population per capita. 78% of the roads are dirt or unpaved, making access to care problematic. Living 2 hours away on a paved road is a problem. Living 2 hours away on a dirt road is a completely another set of circumstances. And so I stopped there with those numbers, not to say, wow, they're poor and we should all go flooding in and do everything we can for them, but to put into perspective, these are equally as bad as statistics as you might find in some areas in Africa and South America and Central America and other places we send residents to, and it's right here in the U.S. And as Jim is saying over there, probably worse, right? Yeah. So now let me take a step back and sort of tell you, what do we have going on there? So this is what we're working in, and what do we have going on? So over the course of 6 years, we worked with a lot of different groups, but from a clinical standpoint, which is what I'm talking about right now, the pediatric clinic there is a well-oiled machine at the Gallup Indian Medical Center, which is what GMC stands for. They have specialists who come from the University of New Mexico a couple times a month for different ones. So cardiology comes like the 2 Wednesdays a month. They have endocrinology who comes once a month, neurology once a month. So these pediatricians are actually starting their first seizure meds. They're starting the kid on insulin drips and getting their basal bolus therapy when they go home with DKA and all this. They're the first line doing it by phone, but they have a specialist who comes and helps them out from time to time. And the way the cardiology clinic runs there is amazing. In fact, our former chair is very good friends with the doctor who runs this program there, and so I've had some interesting contacts after he learned about our work. The pediatric wards are totally hit or miss. If you're there in the summertime, there's going to be like one kid in there with an asthma attack. If you're there in the wintertime, you're going to get community-acquired pneumonia, bronchiolitis, everything you would get on the wards here. So it's anywhere from, they have, I think, 12 beds on the peds floor, but really it's like half of those are peds all year and half are adult when it's low ped census. But during the winter, it can be that many plus more. Now the wards, interesting, does include the nursery as well, the newborn nursery. So they attend high-risk deliveries and take care of all the babies in the nursery, and some feeder growers will stay there on site at their medical center. So they're kind of like a sort of level 1, level 2-ish kind of place. It just kind of depends on who's on and what the situation is. Then they have the Tohatchi Health Center, which is a community health center about 45 minutes north of Gallup out in the res. It's a great experience. It just over the last 2 years has become an opportunity because one of the clinic docs at the hospital took over out there when one of the docs who was there left. So it's opened a door. She's used to having us. And so the residents rave about this experience and beg for more of it. So the problem is you have one attending, so she can't take every resident every day with her. But in this little center, they're doing boluses on people who are dehydrated, some minor procedures, that kind of stuff. So it's really like, in some ways, being out in some of the places we would send people to in other parts of the world. And then there's a whole bunch of community organizations, which we'll talk about in a second. But a little bit about the hospital itself. This is a picture of Gallup Indian Medical Center. When you walk in, it smells like, looks like, everything is just like any VA hospital you've ever been in America. The government does it one way, and that's the way it is. The pediatric clinic itself sits right behind this building. It's your typical outpatient primary care office, Monday through Friday, 8 to 5. They have this side of the clinic is well visits, this side of the clinic is ill visits. They actually segregate sick and healthy kids within their waiting areas, which is really interesting. They have 8 board-certified pediatricians there for our supervision of our residents, which is great. And they love having learners with them. These are the same docs who cover the inpatient. There's no peds hospitalists there. They also cover urgent care and ER if there's a specific peds-related question. So I think of last year there was a big car trauma came in and it involved a kid, and they called the peds docs to come over and help the ER docs manage that until they got an air flight there to pick the kid up and fly him out elsewhere. And again, the specialty clinics are there, like I mentioned. The ward's pretty much what I said. It's a 99-bed hospital. A small portion of that is peds. You do learn a lot about the interaction between adult and pediatrics of specialty care when you don't have a peds ID doc, but you need an ID consult, and it's hantavirus season on the reservation. They have a whole lot to offer you, and so you can start there before you ship a kid off 2 hours or call somebody up far away and try to do tests that maybe aren't available at your center or something like that. So it's a really, really interesting relationship all the docs there have. This is a picture of Tohatchi, like I said, community health center. Surrounded by about 1,000 residents in the community, probably serves just a little bit more than that in the catchment area of what could get there. They have both peds and adult docs on site, as well as a WIC office and a few other things there, which it's not really WIC, it's something else because it's part of the Navajo Nation within the U.S., so they have their own name for it. But it's in all intents and purposes, what we think of as WIC. So then the community experiences, and this is the part that always excites me because I think this is a part where we can learn so much more than just medicine. They vary year to year. It's just like anywhere else you would go. You never know what's going on until you get there. You can call Cynthia over here, probably sends 200 emails every January for our arrival in April and follows up once a month and probably gets a handful of responses. But a lot of times they don't know what's going to be going on, or they don't know which specialist is coming when, or what community group is going to have an event on what day. So it's been kind of interesting. But I start with the first one, which is by far the most well received by the residents, and it's the Office of Native Medicine, the medicine man, the traditional healer, whatever you want to call it. They have a lot of different names there, but Gallup worked really hard to balance the role of Western and Native medicine for their patients and their constituents there in the community. A lot of ceremonies around certain illnesses, death and dying, childbirth, other stuff, but they overcame probably the biggest OSHA obstacle I've ever seen. So this is a hogan, which is the traditional native home. They must have a dirt floor. So to build a dirt floor at a hospital within the United States took many years and lots of red tape cutting, but they got it done. The medicine man invites our residents into this room, and he spends 2 or 3 hours, just depending on how long he feels like talking and telling his stories, about what a native healer does, how he interplays as a consultant with the Western docs. He talks about the history of nobody wanted to go to the hospital many years ago because when you go to the white man's hospital, you come out in a mortar bag. And when you go to the medicine man, you live for a while and then you die at home the natural way. And he talks about how over time that view has changed and people have learned about how important Western medicine can be as a synergistic approach to the native medicine and vice versa. And he tells many stories of ceremonies he's performed and so forth, and sort of really gets to the meat and the potatoes of the culture as an outsider. Like on day one, you need to know before you say something really bad or do something really wrong. And it's the residents, we used to do it later in the rotation, and based on their feedback, they're like, we need that day one. So literally, we schedule, the morning is get your badge, get all your papers signed by the government. The afternoon is you start at 1, Stephen Begay, and you end when you want to end, kind of thing. And that's sort of our agenda for the day, and it's fantastic learning. And Cynthia and I have been to probably half a dozen of these talks, and it's always a little different. It's never the same story twice, so I can listen to it all day long. Another program we've had the luxury of recently becoming a part of, and I'm going to see if this will work or not. It's called the Northwest New Mexico Firstborn Program. So this comes from a large grant from the Kellogg Foundation, a little over $1 million. The area around Gallup, McKinley County had terrible, I don't know if terrible is the right word, but not so good neonatal outcomes in their children and early childhood outcomes. This was based off a program that I think originally started in Michigan. But anyway, this program has funded that patients who meet certain criteria can sign up at the birth hospital, sometimes even prenatally, and their children will get a visit in their home once a week for the first 3 years of life by a health facilitator, not necessarily a health-trained person, but a community health worker equivalent who could be a liaison to the medical service, could be a liaison to community resources. They go in with this huge binder and they have a care plan for every person about like tracking the child's development, mom's needs, dad's needs, and sort of it really takes a whole approach into the kid's whole life. And once a week they get this. So this Dr. Sweeney, who is unfortunately passed, but was the chief at Gallup when we started this, was the leader of this program from the medical side. And so one of the big things was inviting us to go on these home visits with people and learn. So residents come back and they talk about, wow, their house was just like the apartment I live in Cincinnati. Or the other one comes back and like, wow, I went to a house with a dirt floor and no electricity. And so after they each go for at least a day, and they have the opportunity to go for more if they want to. And so they see a whole variety of experiences. And it's interesting because the residents learn a lot, but one of the things that came back is, I was really glad I was there because the mom had a question about the baby's formula, or about the baby's poop, or about using a pacifier. And so they actually had something medical to contribute that the person they were visiting with didn't know the answer to, or wasn't qualified to give her personal opinion to, based on her credentials. So really great program, but you can see here just a few pictures of where they take people out. Sheep for sale, I've actually seen that sign before on the res. But their whole point is to give these kids that right start to make them have a better chance at a bright future. So the third one is, I don't know if anybody's familiar with Jim Campbell, but he won an award from the AAP about 2 years ago. But Jim is a very well-respected physician there, worked for over 20 years at the IHS, actually married a native Navajo woman, which as an outsider is a super big accomplishment to sort of get into the culture as an outsider. But after retiring from the IHS, he then began working with Hopkins on a lot of their vaccine research, primarily HIB and now the pneumococcal vaccine studies. So he's on the res all the time, going hospital to hospital, collecting data, following up on things. And he always takes a couple days, and he'll take our residents in his car with him, and wherever he's going, they go. So they usually leave about 8 in the morning, they get home from anywhere between 4 and 8 at night, just depending on where they go and what the roads are like. And some of the residents are like, we never thought we were getting back from where we were, or we saw houses, or he took us and showed us where this family lived that he used to go out and see when he worked in the southern part of the res. But he also has it in, and so he shows them all the different facilities, the oldest IHS facilities, the newest ones, the ones that are still government run, the ones that are sort of outsourced to the private sector but still fall into the IHS, and just shares all of this insight that is just beyond anything you would imagine or that you would ever read in a textbook about. So he is just above and beyond one of the highlights for our residents as well, and loves the opportunity to meet with learners. This is Bruce Tempest here on the right. He's a former adult ID doc at Gallup Indian Medical Center who every year gives a talk to our residents, and I'm hoping his health will allow him to keep doing that over the next couple of years. But he was an adult ID doc who was there when the hantavirus outbreak first started. Nobody had a clue what it was. He tells stories about people coming in this acute pulmonary syndrome, they called it at the time. They get to the hospital and within 4 or 5 hours they're dead. Their chest x-rays are just a whiteout. Nobody knows what's going on. And so amongst he and a bunch of the other docs in the community and around the res, they started sharing information, talking. They get the CDC to come in, sort of as the Monday morning quarterback at the end once they kind of figured this out. But the CDC comes in and kind of puts the yes, you got it right on there and all that stuff. But he has this beautiful slideshow of walking through the first few cases, what they were facing, how as a doctor in a community, working with those other doctors in the community without some big academic center behind you or anything else, they were able to figure out what hantavirus was and how to deal with it and how to save those people's lives. And he talks about how he started with one case, and then they figured out some relationships, and then suddenly you have a whole series, and the pieces start stacking up, so it makes sense. So really cool information. And in fact, they still have hantavirus every year out there at some point. And our resident who's in Tuba City, one of her first calls, she will tell you one of her first patients was a patient that came in and died with hantavirus, and very new experience for her. There's a program called the Zuni Youth Enrichment Project. The Zuni Reservation is about 30 minutes south, sort of within the Navajo Reservation. It's its own smaller tribe. There's a doctor there who started with a small catch grant of a couple $1,000s from the AAP, moved into this community as a physician, and has really been working to strengthen the community and the outcomes for their children. So we've had the opportunity to meet with him, go out and work with him on some of his programs, things from working in the hospital with him to learning about community activities to just being the big white kids that the kids can use as a practice soccer team for their community team. So he's doing a lot of teamwork, relationship building, basic life skills building. So they have a soccer team, they have a basketball team. So these kids are interacting in ways that are keeping them away from drugs and alcohol and other stuff that is out there, or at least to some degree early in their life. They're learning how to balance a bank account. They're learning how to have tutoring programs through the school. I mean, just a great program. They have a community guardian, learning how to, provide for themselves when scenarios may not be perfect for that. So this is just a picture of their website that's out there. This is a soccer team here, the Thunder Strikers. They have lots of summer camps and different pictures here. And some of the kids are featured there from that site, and that's all available out online. So this will be on the slides for you guys to look at. Sorry. Get back in. Pick up where I left off. There's a department there which we would all call probably public health where we are, but under the IHS it's called Health Promotion, Disease Prevention. A lot of different services to the community. When I was there as a resident, I remember going to a community health center, which was sort of like what we would consider a senior citizen center, and talking with people about diabetes and checking their sugars and how did they do that and did they know how to do it, and just basic education. Other things like community health fairs at the school for kids and parents to come learn how to use spacers with their asthma for their children, because as I alluded to before, probably a nebulizer isn't the best idea for everybody out there. Healthy diet options. They'll take food and show people how to do certain healthy foods and so forth. Really neat group of people who are very dedicated to what they do. The McKinley County Health Commission is sort of like their public health department, sort of steering group or oversight group. They always invite us to come to their monthly meetings when we're there if it's going on. And so I've had everything from seeing how they're going to implement new programs in the school, to how they're going to bring in a large group for cleft palate and lip, sort of a multi-specialty team for a day to one of the local hospitals, whether it be the IHS or the public hospital nearby, and how they're going to work those things out. Other health issues in the school, things like suicide, which is a high rate there, alcoholism, which is a high rate there on the res. So this group really sits and talks about the problems. They have representatives, like I said, from the school, from the hospitals, from the social work sector, through a couple different community organizations that have events going on. So it's a really neat experience. And a lot of times we just sit in the back of the room around this outer table and just watch what's going on, because as a resident in a large academic center, you may not always get to see that going on in the background at your institution. Growing in Beauty is essentially an early intervention program. I'm not sure what it's called in Wisconsin. I didn't Google it, I confess. But in Kentucky, it's First Steps. In Ohio, it's Help Me Grow. But the earlier, 1, 2, 3?
Birth to 3.
Birth to 3. Okay, there we go. So, but it's the early intervention program that everybody else has, with home visits and lots of other developmental assessments. And so we sometimes get to do home visits with them. I've found that this group, sometimes the parents are a little more guarded to having an outsider in, so it's been a little more hit or miss, but they're always very warm and welcoming if the families will agree. Then Gallup Indian Medical Center has these home nursing visits, which are kind of like what we would think of home health, but not really, and